Hello, I'd like to welcome you to our event. Um, this is redrawing the algorithm in gastric and GE junction cancers, treatment planning and sequencing in the era of immunotherapy. I'm Dr. Manish Shah from Weill Cornell Medicine, New York Presbyterian Hospital in New York, and I'm joined by Dr. Zev Wainberg from the David Geffen School of Medicine at UCLA in Los Angeles. Just to frame the discussion, what are the current shortcomings in delivering oncologic care over multiple lines of therapy for gastric and GE junction cancers? And I think this is sort of the reality. These are data from electronic health records from 2011 to 2018, about 3,300 patients, and a third of patients weren't tested for HER2 status, and that's in the last 9 years. That's a significant portion. Of course, everyone should be tested for HER2, but a third were not. In terms of first-line treatment, 25% of patients did not receive treatment after diagnosis. That perhaps reflects a high disease burden and comorbidities, but it perhaps reflects an unfamiliarity for treating gastric cancer. And then the majority of first-line patients, 57%, never received subsequent lines of therapy. And that's also a large number. I think that there are second-line and even third-line options that we need to talk about. And then finally, second-line treatment and beyond, of the patients who did receive treatment for gastric GE junction cancer, approximately half, I said, received second line, but less than a fifth of patients received third line. And then there's the initiation of second line targeted therapy with ramucirumab, for example. A lot of people are not getting that. So really, a key feature is that maybe more training is required to help align treatments according to best practice or best management. And we also need to think about the holistic care for patients. We think that if we can provide comprehensive care, not only chemotherapy, but also supportive care, targeting nutrition and pain management and things like that, we might be able to do a better job treating patients in the first line setting and beyond. So with that, we've learned a lot about gastric cancer over the last 5 years. In 2014, the TCGA published the 4 main subtypes of gastric cancer. And here we see the EBV subtype is highlighted here. These are EBV positive tumors that occurs in about 5 to 10% of gastric cancers, mostly in the fundus and body. A key feature is that they have a lot of PD-L1 and PD-L2 overexpression that may be important for immunotherapy. There's the MSI high subtype, which is largely from the DNA hypermethylation and silencing of MLH1. And 40% of them have PIK3CA and PIK3CA mutations and ERB3 in 25%. And of course, this subtype is expected to respond more often to immunotherapy. The genomically stable subtype, also historically known as the diffuse subtype, these are challenging tumors, but actually there may be a target called an 18.2 might be active in this disease. And then the chromosomal unstable subtype, that's the most frequent subtype and more at the GE junction. And these are more commonly HER2 positive. And so putting this all together within a framework, we think of genetic risk, environmental risk, and then also behavior, and placing it all together. We created this sort of framework to identify where the different disease subtypes are. And a key thing that I always mention here is that in terms of genetic risk, there is a hereditary predisposition syndrome called hereditary diffuse gastric cancer, which is caused by CDH1. And if you identify a kindred that has a CDH1 mutation in the kindred, then the treatment is actually prophylactic gastrectomy. And this is a risk-reducing surgery that will potentially reduce the risk of getting gastric cancer in later years of life. So this is our topic, refining the treatment selection and sequencing in advanced gastric and GE junction cancers with novel systemic approaches. And we'll begin with a case. A 70-year-old retired teacher, Ellen, is diagnosed with stage 4 GE junction adenocarcinoma, metastatic to the lungs. She's married, has 2 children and 3 grandchildren. Her ECOG is PS of 0. She's normal. And some immediate questions occur. Which molecular tests would you perform to guide treatment and predict the course of this disease? What would you recommend for this patient in the frontline setting? What is the appropriate follow-up and monitoring plan? What are the supportive care recommendations? And how would you plan for second and subsequent lines of therapy? And I think it's important to sort of map this out. There are first line, second line, third line options. There are molecular targets that we need to know about. So if we have a plan and a strategy, then I think we're more likely to get people through the spectrum of the disease as opposed to stopping at first line, which we too often see. So here are the NCCN guidelines. In the first line setting, we would focus on a platinum 5-FU based regimen. If you're HER2 positive, you would add trastuzumab. And even just most recently, you would add trastuzumab and pembrolizumab if you're HER2 positive. So HER2 testing is required. And then CPS testing, I think, also helps, and we'll get to that data as well. On the right-hand side, if you're HER2 negative, you have FOLFOX or platinum 5-FU with nivolumab, particularly if you're CPS 5 or higher, that's category 1. Of course, nivolumab is approved for less than CPS 5, but the activity of immunotherapy is less if the CPS is less. Other options in the first line setting include FOLFOX alone or cisplatin 5-FU or 5-FU and irinotecan. And of course, what's not seen on this slide is a 3-drug regimen if your performance status is very high, like FLOT or modified DCF. So here are several of the positive recent studies in gastroesophageal cancers. We'll start on the left, the Checkmate 649 study. This included cancers from the stomach, GE junction, and esophagus. There's only adenocarcinoma, and it was a randomized study of FOLFOX or Zelox with or without nivolumab. It was in the first line setting, as I said, and the high-level data response rate improved from 45% to 60% in the CPS 5 or higher group. The hazard ratio for progression-free survival was 0.68. So that means that there was a 32% improvement in progression-free survival with FOLFOX and nivolumab for the CPS 5 or higher group. And the improvement in overall survival was 3.3 months. So the median overall survival was 14 months with FOLFOX and nivolumab in the CPS 5 or higher versus about 11 months with FOLFOX alone. So that's a substantial benefit, and certainly nivolumab should be given in the first line setting for HER2 negative patients. The other studies of note are Attraction 4, which was a study primarily done in Asia, and it matched the PFS hazard ratio of 0.68. The Keynote 590 study was an esophageal cancer study. This examined chemotherapy with or without pembrolizumab in esophageal cancer, both adenocarcinoma and squamous cell cancer. And based on this study, which was also positive, pembrolizumab is approved for esophageal cancer. And in the CPS 10 or higher group, there was a substantial benefit in overall survival. And the Keynote 811 just was recently reported at ASCO, and that showed that if you're HER2 positive, you would be receiving chemo plus trastuzumab, but the addition of pembrolizumab significantly improved the response rate. We don't have data on progression-free survival or overall survival, but based on the increase in response rate, pembrolizumab is now approved in that setting as well. So here we have the Checkmate 649 Kaplan-Meier curve, and I find this often very useful to see. So the standard arm is the one in orange, and this is FOLFOX alone. And you can see that a median survival of 11 months is quite good for FOLFOX alone. It's about, this arm did as well as expected. The other arm, the one with nivolumab, did much better. And you can see that the curves split early at around 3 months, and it stayed split throughout. And I think it's really important to realize that even at 3 years, about 20% of patients were alive with nivolumab plus chemo. So that's really, really key. The primary endpoint was was the progression-free survival in CPS 5 or higher, and it was highly significant. And then the way that the study was designed is that it looked at lower rates, CPS 1 and higher, and then also CPS all comers, I mean. And so here's the overall survival, and also the progression-free survival, the expanded data set. And you can see that there is still a benefit. So we see the benefit across CPS as well, but the benefit seems to be more in the CPS 5 and higher. And here we see the toxicities, and really with the addition of nivolumab, we don't see an increase in toxicity for CheckMate 649. And so this is actually quite encouraging that we're seeing so much benefit without a significant increase in toxicity. The majority of the non-endocrine toxicities resolved over time, so that's an important aspect as well. But the endocrinopathies, the thyroid dysfunction, the adrenal dysfunction that you can see with immunotherapy were more persistent, and that's what these slides show. So getting back to the case, the 70-year-old retired teacher, Ellen, is diagnosed with a stage 4 GE junction cancer, metastatic to lungs. She's MSS, HER2 negative, and CPS 20, ECOG performance status 0. So, the first question we talked about was what markers, and we gave them to you here. We would check for mismatch repair deficiency, HER2 status, and the PD-L1 status. These all help us with guiding therapy. And we see the markers here, again, MSS, so mismatch repair proficient, HER2 negative, and CPS 20. So it's a high CPS. So Dr. Weinberg, what would you recommend for Ellen in the first-line setting here?
So thanks, Dr. Shah, and thanks for having me. I obviously look at the biomarkers that you just suggested, and here we have a compelling reason to add nivolumab to frontline chemotherapy based on the CheckMate 649 study you just presented. I think this is a clear indication where we would expect and hope for benefit of the addition of nivo to chemo based on that CPS score. So I agree with the proposal, and my standard would be FOLFOX plus nivolumab in this context.
Yeah, thank you. I think that we would all agree on that. But I think the other thing, the next box there is to think about second and third line. And yeah, I know that we're going to talk about that in some detail. But with a platinum in the first line setting, how does that impact your second line and third line treatment options, or how would you think about that? If you want to talk about that for a few minutes?
Yeah, I mean, I think that, we recognize that, platinum 5FU is the mainstay. And here in the United States, certainly, I think we generally adhere to a FOLFOX as our primary platinum, oxaliplatin. We know that a lot of these patients are not going to be able to tolerate beyond 5 to 6 months of FOLFOX. And as you mentioned, the 649 study, these patients are living longer. So neuropathy is important to manage. And if capping the dose of oxaliplatin at somewhere between 4 to 6 months, depending on what is your standard practice, I think is very reasonable nowadays. And continuing along with the fluoropyrimidine with the 5FU with nivolumab would be my best approach while you plan for second line. And I mean by that, you keep in the back of your mind that these patients are likely going to progress at some point in time. And at that point in time, additional chemotherapy and/or targeted therapies may be appropriate.
Yeah, exactly. I think that's exactly right. I think that keeping an eye on the neuropathy early on is important because you can get mileage with taxanes down the line. And I actually have recycled oxaliplatin in the first line setting. We stop oxali after 4 to 6 months, as you say. We continue 5FU and the checkpoint inhibitor, and then maybe 6-9 months later, if they progress a little bit, you could. I mean, this wasn't studied in 649, but from a real world management standpoint, before going to second line therapy, I sometimes go back to oxaliplatin and can still get mileage.
Yeah, I agree. And thinking about it as, as we've become accustomed to with colorectal cancer is becoming more in tune with how we manage gastric cancer. I will say that obviously, we don't have always the luxury of having these prolonged disease-free or opportunities to re-challenge in this disease as much as colorectal cancer. But when you are fortunate enough to do so, it is a good strategy. I completely agree.
Perfect. So, the other question that comes up is, what should you consider when monitoring and planning for disease progression early on to avoid treatment delays in the second line setting and beyond? So, in the second line setting, a lot of patients we've learned really don't receive second line therapy. Actually 57% of them don't. And then third line therapy, only a quarter of patients do receive third line therapy. And we think that a large part of that is the disease burden. Patients with peritoneal metastases may have a challenge with their peritoneal disease and maintaining nutrition and their performance status and things like that. But I think actually a lot of it can be managed with a more holistic approach. So with the idea that we have options in the second line and third line, we want to kind of anticipate what some of the side effects or some of the management issues might be, thinking about supportive care, nutrition, pain control, things like that. So, I'd like to point out that malnutrition is very common in gastric cancer patients. And more than 85% of patients with gastric cancer do have evidence of malnutrition. And the consequences of malnutrition are significant. There's impaired functioning, worsening quality of life. There's greater severity of cancer symptoms, decreased response to therapy, increased toxicity, and more frequent and more severe complications. More often, patients get admitted to a hospital, and there are higher healthcare costs and shorter survival time. So it is a key aspect of trying to manage these patients is to realize, understand their nutritional status and address it early on. And that's a key aspect. And I think educating the patient is also quite important. I think if you think about it, every time you eat, a patient might be reminded that they have the cancer because it may be causing pain. That the cancer is in the stomach, so it's even growling hunger pains could remind them of the cancer. So this is, I think, a key feature. So we really think of a multidisciplinary or holistic team approach to managing patients with stomach cancer, or stomach and esophageal cancer. Historically, we thought of multidisciplinary approach as surgical, medical, and radiation oncology, but I would submit that it's actually much more than that. There's GI, there's our oncologic nurses, pathology, nutrition, social work, palliative care. They all are involved in helping manage our patients. And I think coordinating care along this spectrum will, in the end, help patients overall. So patient education is very important. It's important to remind patients that they do have choices for treatment planning. So we talked about, FOLFOX as the mainstay, but actually the NCCN guidelines also allow irinotecan. So if your patient uses their fingers and needs their dexterity for their livelihood, for example, then starting with FOLFIRI is appropriate. So make sure patients understand the upfront assessment. I think it's often helpful to talk to them about the biomarkers, and sometimes that may delay starting treatment for a week or two. Having them, involved in this decision making helps them understand why there's a delay and how the delay actually in the end might help them, because it may help tailor the treatment specifically. And then also helping them understand the extent of their disease, the likely side effects that they may develop over time, and how they can be managed. And it's important to be prepared when you talk to your patients about the diagnosis itself, the prognosis, the treatment choices, and sort of the qualitatively how decisions are made with regard to week-to-week dosing. I talk to my patients. I anticipate that everyone will get neuropathy on oxaliplatin. The point is just when. So, and I actually explained to them that the neuropathy actually gets worse even after stopping oxaliplatin. So we have to almost anticipate that this is going to happen. So you stop the oxaliplatin appropriately. I think many of us who see a lot of GI cancer patients, we're used to this, but I think the reality for gastric cancer is that a lot of gastric cancer patients are managed not at academic centers where physicians see a wide spectrum of diseases. So they may not be as familiar with some of the toxicities and some of the things that we're talking about. So I think this is why this is important. There are a lot of practice tools that are helpful in managing these patients. And so I think, here's a summary of a lot of the common issues that patients have. Fatigue, nutritional deficiencies we talked about, indigestion, osteoporosis and osteopenia, diarrhea, dumping syndrome, particularly after surgery. So, patients who are diagnosed with localized disease, they have a distal subtotal gastrectomy. They may sometimes have dumping syndrome. And so managing that is important. Often dietary changes, subtle dietary changes can actually help patients manage that better, weight loss. So we've provided a lot of the information on supportive care recommendations with this learning activity, and you can download this from the link that we shared earlier. And then this is, a key thing issue. So the supportive care starts before treatment. I think a large part of it is, anticipating and giving your patients and your nurses the tools to manage often a lot of the side effects. So acute bleeding can be managed endoscopically, for example. Chemotherapy-induced neuropathy, we talked about that. Duloxetine, I think, can help. Gabapentin can help. Diarrhea, we've talked about that. A key side effect of the chemotherapy that we give. Peritoneal disease, that's a common issue with gastric cancer. And so frequent small meals can help manage the nutritional status and diarrhea and pain that can occur with that. And so for patients with gastric cancer, interventions undertaken to relieve symptoms and maximize quality of life will ultimately prolong survival. So I think it's really important to be proactive here, support your patients before starting treatment. And that includes assessment of the patient support systems, referral to nutritionists, social workers if needed, and adequate education. And again, we've provided a practice aid with this activity that I think could be very, very helpful. So I think this is our case here, CPS 20 HER2 negative. And now she's gotten FOLFOX and nivolumab, and she had progression. And I'd like to hand it over to you, Dr. Weinberg.
Thank you, Dr. Shah, and thanks for the introduction to the case. And as we talked about, we made a conscious decision to include nivolumab in this patient's case, and we'll touch on that, on why, the rationale behind that later. The patients in this case had tolerated treatment well, but as with almost every patient with metastatic gastric cancer, eventually the patient progressed. But at that point, the patient remained with a good, adequate performance status. And what's our standard second-line option? And as you pointed out, really, we're not globally doing a great job making sure that enough patients get second-line therapy. And that's a critical thing, because I think, when you think about other cancers, we do have a higher integration of second-line therapy into their continuum of care. And so one of the things that is critical in gastric cancer management is that progression can happen in any number of ways. It can happen primarily based in my experience, based on clinical symptomatology, that you see the declining weight, you see the weight loss and the abdominal, the difficulty eating and the anorexia. And you incorporate that with a tumor marker maybe, or with the context of a CAT scan. So it's not just simply a CAT scan showing you that you're progressing, but incorporating clinical deterioration with all of those features. And as you can see here, that's a clue that we ought to be thinking about a second-line regimen a little sooner in many patients. So when we think about globally gastroesophageal adenocarcinoma, we ask ourselves, what are the second-line options for these patients? And there's obviously a number of them now that are recognized. We'll be going over some of the landmark studies, and the first one we'll highlight here is the Rainbow study. So the Rainbow study was a large international randomized phase 3 trial that looked at paclitaxel with or without ramucirumab. And obviously ramucirumab is a known VEGF-R2 monoclonal antibody that inhibits angiogenesis and has been known about for a number of years. And the study looked globally at patients, now study published 7 years ago, but looked globally at patients who progress on fluoropyrimidine platinum therapy and were ultimately randomized to ramucirumab plus paclitaxel or placebo plus paclitaxel in the standard 3 weeks on, 1 week off regimen. And this patient in the study here, which is well known to everybody, has been published for a number of years now, did meet its primary endpoints, both from progression-free survival and overall survival. You can see on the left, the overall survival hit a median expectation of 9.63 months in this study versus 7.36 months with paclitaxel alone. So an improvement of about 2.5 months, or almost 2.5 months of median overall survival with the group of patients who received Ram-Pac over Pac alone. And in PFS also met its endpoint with a hazard ratio of 0.635. Now, the important thing to think about is that this has remained, despite several studies trying to change the standard of care, this has remained, in my opinion, the standard of care for second-line gastroesophageal cancer. And so that median survival expectation of 9.63 months in the second line remains our reference standard 7 years later. Subsequent studies have reinforced the value of adding ramucirumab to paclitaxel. Here's a Chinese study. As we know, this is a disease obviously heavily centered in Southeast Asia and in the APAC countries. And here, one done out of China also showed improvement of survival, both on PFS and OS. Certainly a smaller study, but something that demonstrated the benefit in a single country as well. And more importantly, over the last 7 years, we've seen a number of real-world experience studies that we've all been involved with, collecting this data, trying to see if indeed we can demonstrate that by and large what was demonstrated in the large phase 3 studies can also be seen in the real world. And in fact, for the most part, these have recapitulated across the world, real-world experiences with Ram-Pac to show similar survival expectations to what was demonstrated in the randomized phase 3 trial. And real-world experiences are critical to advising, obviously, community oncology and also our general experience, because we know that not all patients are going to be eligible for every phase 3 trial, but we can bring in real-world experiences in retrospective studies to review and reinforce our conviction that in fact, Ram-Pac is an appropriate second-line therapy outside of phase 3 registrational studies. There have been a number of other approaches to looking at anti-angiogenesis combinations. We've all been involved in these studies a number of years in gastric cancer. We'll highlight a few here because I think that FOLFIRI is an underutilized regimen in gastric cancer. I think irinotecan is an active drug in this disease, as Dr. Shah alluded to, and certainly can be utilized either in front line in some contexts or more likely in second and or third line, particularly if the patient had received paclitaxel. And by that, I mean, we know that or taxanes are getting increasingly used in perioperative scenarios. So as FLOT has emerged as a more recognized global standard for perioperative management of gastric cancer, we, of course, are using it with FLOT, which is obviously a triplet drug regimen used primarily in the perioperative setting. But of course, what's going to happen then is we're going to have more patients progressing on that, and some, unfortunately, progressing right after surgery. And how do we deal with those patients? And I think a good thing that a lot of us have used is FOLFIRI, because that's a novel cytotoxic. They've received their taxane, but they haven't received their irinotecan. And that can be safely combined and effectively combined with ramucirumab. And that's a regimen that's been well published in colorectal cancer. And here as well in gastric cancer, we see studies that were presented in Germany and other countries showing survival expectations in the second line that align very favorably with paclitaxel ramucirumab in some respects. So, thinking about other options beyond just PAC-RAM that incorporate anti-angiogenic approaches are very reasonable, particularly in select patients. And accordingly, the NCCN recognized that and did add, ramucirumab and paclitaxel and ramucirumab and FOLFIRI to its list over these last few years. So what about patients what about other taxanes? And I think there have been other smaller studies to look at this. Docetaxel is another taxane. It's, as mentioned, used in FLOT, but can also be reasonably used as a second-line regimen if you prefer docetaxel for whatever reason over paclitaxel. Here we have a study that supports it. We have docetaxel in this study given at 16 per meter squared. Along with ramucirumab 8 milligrams per kilogram on days 1 and day 15 of a 4-week cycle. And we could see here that this study was presented with the primary endpoint, a small study, but presented earlier this year at ASCO GI, or at ASCO, I should say. And in fact, demonstrated safety, certainly, that we can feel comfortable with using it in that context. What about single agent ramucirumab? And, obviously, there is an older study called the REGARD study, which was the first randomized phase 3 trial of ramucirumab in gastric cancer about a year or two before the PAC-RAM Rainbow trial was demonstrated. And here we saw a role for single agent RAM. This is not used as commonly nowadays because I think nowadays we recognize that continued chemotherapy with the cytotoxic is really important in this disease. But in certain contexts, and those are circumstances where people simply can't tolerate paclitaxel or other cytotoxic agents, one could consider single agent ramucirumab, as it did demonstrate a PFS and statistically significant OS benefit in this study with a hazard ratio of 0.77. So we do recognize this is an option as well. Now, NCCN guidelines have been changing for second line, and we'll go over some of these. It's changed quite a bit, and this downloadable tool is still available for you to look at. We have preferred options on the far left, which include RAM-PAC, which I think is the globally recognized standard, category 1. We now have T-Dxd, which we'll talk about in a moment, for HER2-positive disease selectively. And we have other single-agent chemotherapy options, docetaxel, single-agent, paclitaxel, irinotecan, FOLFIRI, and in later lines, TAS-102, which we'll talk about a little later. There's other options, which include single-agent RAM, other cytotoxic options. Those are different iterations and combinations. And in select patients, if one hasn't yet used, for example, a checkpoint inhibitor in MSI, we'd certainly want to use that in second line if one hasn't used it already in front line. And in the very, very rare NTRK fusion patients, we have 2 NTRK inhibitors that ought to be considered, certainly no later than second line, in my view, in this context. Now, going back to our case, we talked about the patient. She ultimately progressed, Ellen, on frontline FOLFOX/nivo. We know the patient's HER2 negative. Dr. Shah, I think, would you agree that paclitaxel ramucirumab is the appropriate second line for that patient?
Yeah, exactly. I think that's it's a standard. It actually works pretty well. I think, the real world data that you presented, really highlight, if people look at that slide again, the average survival of the patients who received Taxol RAM in the real world setting was still 9 to 10 months, which is very similar. It actually mimicked the Rainbow study very well. And a lot of times when we see real world data, it doesn't quite match the patients who are on the, who are participating on the clinical trial. That often is because patients are selected. But this, the fact that these real world data in over 1,000 patients suggests that really there is clear activity. And so, yeah, in my practice, I think paclitaxel RAM would be really consider the second line setting. And I think you also mentioned this as well about FOLFIRI. So, Ellen received FOLFOX Nivo in the first line setting. Depending on her neuropathy and what she's doing, if she has significant neuropathy, you might, consider FOLFIRI-RAM in the second line setting instead of paclitaxel, just from a toxicity standpoint. But I think irregardless, the VEGFR2 inhibitor ramucirumab does have activity, better than doing chemotherapy alone.
Yeah, I agree. And, I think that, FOLFIRI in some ways is still underutilized. I completely agree. Now let's switch gears a little and we'll revisit Ellen and assume that in the beginning, instead of Ellen having HER2 negative disease, she had HER2 positive disease. And for the purposes of this discussion, certainly we'll qualify HER2 positive as being 3+ by IHC, regardless of FISH status. HER2 3+ is considered HER2 positive in gastric cancer. And now we have new data and exciting data that emerged, and you presented the response rate data, which is all we have, of a combination of fluoropyrimidine, cisplatin, trastuzumab, and pembrolizumab. Do you agree with that approach in this patient instead of FOLFOX Nivo?
Yeah, I mean, well, so I think the data from Keynote 811, was a fluoropyrimidine cisplatin. So I think that's very, very reasonable. I think in practicality, a lot of us would like to use oxaliplatin here, and we would figure out how to do that with pembrolizumab. The Zelox plus trastuzumab and pembro would be probably a reasonable option because the treatments line up every 3 weeks. So that's something to consider. But conceptually, the idea of doing a platinum 5-FU combination with trastuzumab, which is standard, but with pembrolizumab because of the higher response rate, is very, very reasonable. I just might mention that there are very few patients, but they do exist, where immunotherapy is somewhat contraindicated. If someone has inflammatory bowel disease or really bad arthritis, these things could actually prohibit the use of immunotherapy because it could actually aggravate these symptoms and really diminish the patient's quality of life, or it actually could be even life-threatening. So that pembrolizumab is practice changing, no question, or nivolumab. Both of the PD-1 inhibitors available are practice changing, but I think and we should use them in first line setting as a rule. But I just would encourage our audience not to forget about some of the contraindications and the toxicities.
I completely agree. Just yesterday, I had a patient with pretty substantial rheumatoid arthritis, actually. So,
yeah.
We had a long talk about that, and it's definitely something that we have to keep in mind. And the HER2 patient population is in some respects quite different, and we recognize that. So we have the ability to add trastuzumab. Up until 6 months ago, we were all adding trastuzumab here to chemotherapy, and now we have the possibility of adding pembrolizumab based on the FDA approval just in the last few months. What's interesting now is that HER2 has changed because it also has changed the front line, and it certainly is changing what we ought to consider in second line. There's been a lot of talk about, should we rebiopsy these patients in second line, or should we rely on the archival HER2 positivity and not rock the boat too much? I wonder what your thoughts are about rebiopsying Ellen in this context.
Yeah, that's a great point and a great discussion. I know that you're going to talk about that soon. The FDA label recommends a new biopsy prior to using in HER2, but it doesn't require it. And on the Gastric 01 study, a rebiopsy was not required also. And the data that I've seen, I don't think this is published, is that they looked at patients where a rebiopsy was done versus the other patients, and the activity seemed to be similar. That being said, and I think it's something that you'll talk about, and HER2 does have some significant side effects, with regard to pneumonitis and things like that. So, in my practice, I in general do prefer to rebiopsy, but it's not always feasible. So, and the implication is that if you do rebiopsy and they turned out to be HER2 negative, because remember, gastric cancer is quite heterogeneous. I think you're right to point out that IHC 3+ is considered positive, but if you rebiopsy and it turns out that the remaining tumor is actually IHC 0 or 1+ and FISH negative, then you may not consider HER2, and then in that case, paclitaxel RAM would still be the standard therapy.
Yeah, I'll remind the audience of the Keynote 811 study that Dr. Shah just alluded to. And here you could see in the data that was presented at ASCO 2021, the response rate of nearly 75% with pembrolizumab plus chemotherapy plus trastuzumab versus 52% with the patients who, this is frontline data, I should mention, chemotherapy, trastuzumab on the right in red, chemotherapy, trastuzumab plus pembrolizumab in blue, showing an impressive improvement in response rate corresponding with a very similar response rate that was presented in the phase 2 study a couple years back. And of course, we're eagerly awaiting the progression-free survival and overall survival updates on this study, which hopefully will be present in a year. But for now, certainly the FDA considered this response rate to be sufficiently encouraging that allows us to use in all patients with HER2 positive upfront chemotherapy plus trastuzumab plus pembrolizumab. Now, moving on to the second line case, going a little backward and forward here, Dr. Shah was alluding to this study, Destiny Gastric 01, which looked at trastuzumab deruxtecan. And for those of you who aren't familiar with this drug, it's a antibody drug conjugate that binds HER2, but also has a linker and a payload. And many of us are familiar with this, perhaps from other malignancies like breast cancer. But this is the premise here, that we're going to go ahead and bind HER2 perhaps tighter and allow the payload to be introduced selectively in perhaps more HER2 positive expressing cells. And in this study, which was done only in Asia, it was a randomized phase 2 study. The randomized patients to physician's choice of chemotherapy in second line and third line metastatic HER2 positive gastric cancer. So patients who were pretreated with chemotherapy plus trastuzumab. And it came in the face, I should mention, of a number of negative HER2 positive studies in second line. This was the culmination of 4 studies in HER2 second line, including TDM1, which you all know is another ADC, and Herceptin or trastuzumab beyond progression study with paclitaxel, which failed to meet their endpoints. And here we had a new study, which this one did show an improvement in response rate, which was the primary endpoint of the study, from 14% with single agent chemotherapy. And the physician's choice chemo here was either a taxane like docetaxel or paclitaxel or irinotecan, to 51% with the addition of trastuzumab, or with the substitution of chemotherapy for the ADC trastuzumab deruxtecan. And the response rate, confirmed response rate, actually went from 12 to 43%. So quite impressive improvement in response rate, disease control rate as well. The PFS also improved from 3.5 months to 5.6 months with statistically significant values, and a hazard ratio of 0.59 in overall survival, improving from 8.4 months to 12.5 months. So this really, in my opinion, was practice changing, did lead to the FDA changing their approval and allowing us to use this drug in second line HER2 positive metastatic gastric cancer. And here you could see the waterfall plots demonstrating the improvements, recognizing this as a 2-to-1 randomization to encourage participation. Patients randomized 2-to-1 to trastuzumab deruxtecan on the top versus physician's choice chemotherapy. Now, when you look at the Kaplan-Meier curves, and you have to keep in mind this was a randomized phase 2, so we're used to seeing much bigger studies with Kaplan-Meier curves. These are usually randomized phase 3s. This was a randomized phase 2 study. We did see the curves separate fairly early and stay separated throughout the course of the study, both with respect to progression-free survival and overall survival. And when we see that, we're always, quite pleased that this is a real effect that can be quite durable in a number of patients. And in totality, if you look at this data set, that's what really led the FDA to issue their approval for second line and beyond patients. Now, when we think about second line, in many respects, we also have to start thinking about third line. We have to have our eyes on what do we consider to be a reasonable third-line approach or subsequent line. In HER2 negative, we're obviously going to try to maintain Pac-Ram for as long as possible, but eventually those patients are going to progress too. And in HER2 positive, if they've gotten T-Dxd or the ADC, now they might be a good candidate for paclitaxel ramucirumab, for example, in third line. But what do we do in all comers and subsequent lines? And we do have some randomized data sets to speak of here. We have a large randomized phase 3 global trial called the TAG study, published about a couple of years ago. And this study randomized global patients, meaning globally enrolled all patients, not just Asia, but in US and EU as well. And it randomized patients to either TAS-102, which is a drug we're all familiar with, perhaps from colorectal cancer, trifluridine tipiracil, versus placebo. And at that point, certainly the standard of care was placebo in third-line metastatic gastric cancer. And this study did meet its primary endpoint, improved survival by a couple months in the median survival with a hazard ratio that met statistical significance. So, you know, whether this is an appropriate option or not depends on the individual patient. It depends if that patient can swallow pills appropriately. Depends if that patient wants to keep going. Depends a little bit, in my view, about what the goals are and expectations are of whether or not that the toxicities which are demonstrated, which we're familiar with, have to do with cytopenias primarily, or lab values are worth it for that individual. That's an individual discussion. But we do know that the study allowed us, the study met its primary endpoint, which allows us to consider it for our patients in this context. So when we think about, you know, going back to this slide and this treatment algorithm concept for patients with metastatic gastric or G junction, we recognize that we've got to consider HER2 very early, because it not just changes frontline therapy now to consider an anti-HER2 antibody like trastuzumab, but consideration of pembrolizumab. And what do we do if they're HER2 negative and they have a CPS low score? We'll talk about that in a minute. But certainly we would consider checkpoint inhibitors up front in those patients. And we'll talk about in which context after our Q&A. Perhaps it might come up. But paclitaxel ramucirumab, second line, T-Dxd if they're HER2 positive, and a number of the other options with third line considerations as well. So really, in this program, we will have some practical considerations, some key take-homes. We want people to recognize this is a disease that requires a good, solid multidisciplinary care, a good discussion with the overall holistic approaches that we've heard about, and thinking about goals of each individual patients.
Well, that was terrific. Thank you, Dr. Wainberg, for that update on second line and beyond. I think, you know, it's really terrific that we have options beyond first line, and I think with the, you know, programs like this and the discussion that we have, you know, hopefully more and more people will get second and third line therapy. You mentioned earlier about first line therapy, you know, our patient Ellen, who had a CPS of 20, HER2 negative, and I think we were both in agreement that nivolumab should be given. You know, here are some audience Q&A questions, and I'd like to start off with actually a key question that several of these questions highlight is, you know, are there patients who are the, you know, most appropriate candidates for upfront immunotherapy with chemotherapy?
Yeah, it's a great question and a timely question, because I think we're all, you know, reacting to both the FDA approval, which allowed technically all patients to receive with metastatic gastric cancer chemotherapy with fluoropyrin platinum plus either nivolumab in the context of metastatic gastric cancer and esophageal cancer, or chemotherapy plus pembrolizumab based on the Keynote 590 study, to allow patients to receive some derivative fluoropyrin platinum with pembrolizumab upfront is also an FDA accepted option. And the FDA left it blank on CPS score, as you know, and they basically allowed oncologists to use the drug upfront regardless of CPS status. And that's a critical thing, because I think that kind of is, you know, for many folks a bit confusing, because we've been talking for many years about CPS, and and what it means and how patients, we should take it into account. Now, because the FDA allowed you to do it doesn't mean you have to do it. And I think we're all facing that reality nowadays. And when we should look critically at the data sets that have been presented. And, when I still look at CPS score, and I think we'll continue to do so, because what I look at, an individual patient context, I look at the totality of the evidence. And, in my perspective, the totality of the evidence across a lot of these studies have suggested very little benefit from checkpoint inhibitors, either by themselves or with chemotherapy, in CPS 0 patients. So, and I will say that this is not an easy topic, because it's sometimes you don't want to not give the immunotherapy you'd like to. I think we all are eager to allow patients access to immunotherapy, but we don't have to do it if we don't feel that the risk-benefit ratio is worth it in a patient who might get very little benefit from the drug. We're waiting for a lot more data. I think there's a number of other studies that may shed some additional light on this. But if you look at some of the larger studies, the Checkmate 649, the Keynote 590, and you look selectively at the CPS less than 5 patients, to me, the benefit is less clear in those group of patients who got chemotherapy plus Nivo or Pembro over to chemotherapy arms alone. So personally, I've been approaching it and thinking about each case. But if the CPS is 0 or under 5 for that matter, I'm very comfortable using chemotherapy alone. If the CPS is above 5, I have been now employing either Nivo or Pembro, depending on esophageal or gastric or both. To me, you can look at all data sets together and decide what you like in upfront patients.
Terrific. I think that's, I think a lot of us do practice that way, and maybe, this is another question on this list here. You mentioned about it's really weighing the risk and the benefit. And the benefit, I think, as you rightly pointed out, is less and less with CPS that's less than 5 or even lower. But let's talk a little bit about the risks. I think we had a little bit of a discussion about some of the contraindications, but maybe you could highlight some of that. Like, what are the impact of specific adverse events to immunotherapy that would make you sort of question it or increase the risk in the patient? Yeah.
I mean, I think we all need to look at that. And I think that, we touched on some earlier, some immune-mediated side effects. If anybody has certainly dysfunction of severe rheumatoid arthritis, any autoimmune disease that makes us worried, whether it's ulcerative colitis or low-grade, even a low-grade autoimmune condition, you've got to think about it particularly hard in the patients who have a CPS low score. So I mean, for me, incorporating some of the unique side effects of those drugs with the CPS score is sort of part of the calculus of risk benefit. So in a patient who's got a high CPS score and has a little bit of arthritis, well, I think there it makes a lot of sense to use the drug. The risk benefit ratio is there. But in a patient with a CPS very low score, who you may still want to use the drug, which you're able to, any degree of severe autoimmune condition or even moderate autoimmune condition would make me think long and hard about not using it. So I think that's got to be part of the calculus beyond the typical stuff that we consider when we should be adding these drugs or not.
Yeah, I completely agree. So I think maybe just to sort of summarize this portion of it, what we're really, I think Dr. Weinberg and I are both saying is that immunotherapy is practice changing and transformative for gastric and esophageal cancer. In esophageal cancer, that's adenocarcinoma and squamous cell cancer, at least with regard to pembrolizumab. The higher your CPS, the more likely you'll benefit from immunotherapy when combined with chemotherapy. And the lower your CPS, conversely, the less benefit there is. CPS is a surrogate for the immunosuppression that's in the immune microenvironment, but there may be other signals that we don't know about. So we're not saying that it's a hard and fast rule, and the FDA didn't say that as well. The way that the trials were designed, the FDA had to give approval for all comers because the the alpha value was given not only to the CPS high score, but then also it stepped down to the lower CPS. But as Dr. Weinberg said, because it's approved, at the end of the day, we're all physicians. We look at the data. We should do what we think is best from a management standpoint with our patients.
I think just the key point is I don't think any of us, I know none of us really consider CPS to be a good biomarker for this condition. It's not. It simply is probably the best we have outside of MSI status. So we just it's one of the variables that we need to consider.
Exactly. So this is a nuanced issue, and that's why it's important that we spend some time talking about it. So another question that's here is, what would be the appropriate second line option for a HER2 negative patient who received first line FOLFOX/nivo, for example?
Right, and to me, this right answer is still paclitaxel ramucirumab. There is no suggestion at all in the literature, and maybe we'll see one day additional studies, that changing the immunotherapy or continuation of the immunotherapy is the right thing to do. And by that I mean, if someone got FOLFOX/nivo, there is really no reason to continue the checkpoint inhibitor in second line if they've actively progressed. Maybe one day that'll change, but as of now, that's certainly the right thing to do, is continue a standard second line approach. And to me, the gold standard here remains paclitaxel ramucirumab. Well, what's interesting is, there have been small data sets and recent publications suggesting that the benefit of perhaps the anti-angiogenesis addition to chemotherapy may be enhanced with preceding checkpoint inhibitors, and that's based on the interplay between immuno-oncology and VEGF inhibition, so priming the tumor, so to speak. But and those are retrospective, but perhaps a story to be considered there. But I consider still a paclitaxel ramucirumab to be my standard of care here.
Yeah, I agree completely. But you make a good point about the biology. I think as we get more information with the sequencing, we'll hopefully learn about that. And then I might take the last question, which is, what would be the appropriate second line option for HER2 positive patients who are treated with trastuzumab in the first line setting? So I think this is an important question, and it's an opportunity for us to remind people that gastric cancer is not the same as breast cancer. So historically, in breast cancer, if you're HER2 positive, you continue trastuzumab or HER2 inhibition with lapatinib or pertuzumab or T-DM1 throughout the course of the patient's life. That's not the case for gastric cancer. We have a lot of negative studies in gastric cancer. Lapatinib is not effective in the first line or second line setting. T-DM1 was negative in the second line setting. Pertuzumab, although did show some benefit, was technically a negative trial in the Jacob study. So gastric cancer, HER2 positive gastric cancer, is not the same thing as HER2 positive breast cancer. That being said, we now have an option for patients who are HER2 positive who progress on first-line trastuzumab, and that is trastuzumab deruxtecan. And particularly if you remain HER2 positive, this drug is really outstanding with a 50% response rate. I think we don't see that with chemotherapy even. So it is quite encouraging. The toxicity of that drug is important to realize with regard to, it's rare, but it can happen, interstitial lung disease and pneumonitis. So it's something to watch out for immediately. And if you do have patients who receive that drug and get short of breath, you have to start steroids right away. That's a key feature for that drug. And, Dr. Weinberg, any comments on that?
No, I think we have to keep in mind it is an ADC and it has a potent chemotherapy payload. So, patients get beyond the ILD, which is a unique toxicity to that drug. We also see some chemotherapy toxicities. So to think about those things, some cytopenia, some hair loss, some nausea. So, it's not an antibody, it's an ADC. But I completely agree with your assessment.
Perfect. So I believe that our time is up. And thank you. And Dr. Weinberg, thank you. It's always a pleasure. And have a great day.
This activity is accredited by Medical Learning Institute, Incorporated. This activity is developed with our educational partner, PVI, Peerview Institute for Medical Education.